Yes.
Okay, great. So hello, I'm Shaimaa Mohamed. I'm a fourth year medical student, and today we're going to be learning about anemias. The end goal of this session is that, inshallah, if we all are able to pay attention throughout, then we should be able to memorize it and not have to restudy it again, inshallah. So for today's session, So the outline of this session, we're going to go over the definition of anemias and then some common presentations, the investigations, and then the classifications of anemia, and then these three diseases, specifically these three anemias. So starting with the definition. So what is anemia? Anemia is described as low hemoglobin or hematocrit, which we will get to know right now, for age and gender. So the keyword is age and gender. So for example, here we have what would be described as anemia for these like different types of the population. So newborns, for example, it would be anemic if you had a hemoglobin of 12, but it would not be anemic for an adult female. So yeah, basically it depends on the age and the gender. So what are some common presentations of anemia? So obviously, the major function of the blood is to carry oxygen and transport it throughout and give it to the tissues that need the oxygen and so on. So if you have less of this hemoglobin or less of this blood, then you would have less oxygen, and this lack of oxygen would give you some fatigue and tiredness. And again, the lack of blood cells, it would show as pallor sometimes, like you have less blood. So from these pictures, for example, which one is more pale? This one or that one? First or second? So like the second one is more pale, right? And here, this one looks paler in comparison to that one. So this is how pallor would look like, either like conjunctival or you can see it on the skin. And each specific type of anemia would have a specific presentation that you can kind of like diagnose or try to like understand what kind of anemia it is. And we're going to look at these when we look at the specific types of anemias. So when someone presents to you with some symptoms of anemia, you have to do investigations. And there are first-line investigations and second-line investigations. So first line, you're trying to look at what is the most likely cause or something. So you have like anemia, and you're trying to know what might have caused it. So then you do the first line. And then the second line, you're trying to confirm or try to know specifically exactly the cause of this anemia. So the first line tests would include complete blood count, CBC, and we're going to look at that, and reticulocyte count. And then second line would be electrophoresis. It's part of another pause session, so we'll not go into it. And then other like specific tests like serum iron, B12 folate, and bone marrow examination. Starting with the first line, which is CBC. So what is CBC or complete blood count? It's a blood test that measures like many different parts of the blood, like the blood cells, the specific features of the red blood cells, the white blood cells, and all of these things that are listed here. However, alhamdulillah, for today, we don't have to look at all of it. We're just going to look at this red box here, which is the red blood cells and the characteristics of these red blood cells. So these are the things that we're going to look at today, right now. So the first thing is the red blood cell count. From its name, can anyone guess what it means? Exactly. It's the total amount of red blood cells in the blood. So that's what red blood cell count is. And therefore, if it's below normal, then the person is anemic, right? What about hemoglobin? Hemoglobin, as we know, is the protein that carries oxygen in the blood. But in CBC, it measures the concentration of hemoglobin in the blood, okay? Then if it's below normal, then the patient is anemic. Hematocrit is basically the percentage of blood volume that is composed of red blood cells. So it's basically the volume of the red blood cells in the blood. And if it's below normal, as we mentioned before, then it's anemic. And the question in your mind might be, what's the difference between hematocrit and red blood cell count? So red blood cell count looks at the number of red blood cells. Hematocrit looks at the volume of red blood cells, okay? Now the more difficult ones, so mean corpuscular volume or mean cell volume, MCV. It's basically the average size of RBCs, okay? So the size of an RBC. If it's below normal, then it's microcytic, micro meaning small, cytic. If it's normal, then it's normocytic, so normal. And if it's above normal, then it's macrocytic. And if you realized I did not put any numbers here, inshallah, in the exam, they're going to always give you the reference ranges. So just look at it and compare. Is it higher than the reference range? Is it within the reference range? Or is it below the reference range? To be able to label it as microcytic or normocytic or macrocytic. Okay, so here we have an example. This first picture, is it micro, normal, or macro? What do you think? If you compare it to the others. You guys can unmute to answer if you want. Okay, yes, so this is normocytic. What about this one?
This would be micro.
This is microcytic, perfect. And this one?
Macro.
Macrocytic, okay. So you'll be able to see it from the MCV, which is in the CBC, okay? The other thing is red cell distribution width. Since we already talked about MCV, which is the average size of the RBCs, RDW looks at how the sizes of the red blood cell differ. So are they all almost the same size, or are there some that are bigger than others and some that are smaller than others, and there's a lot of variation? So it's basically the variation in size of RBCs, okay? If there's little variation, like almost all the cells are the same size, then you would call this low RDW or normal RDW, okay? But if there is a lot of variation, high variation, then this would be high RDW. The other name for like having high RDW or like different sizes is anisocytosis or anisocytosis. The real reason why it's because an means not, iso means same, cytosis means cell disorder, so they're not the same, so they're all different sizes, right? You can also remember it as like any size cytosis. It's very important to know like the name anisocytosis, okay? So try to remember it somehow. So here we have two pictures. So would this be, what kind of RDW is this, low or high?
Low.
Yes, it's low. Or normal, and this one?
High.
It's high.
Or isocytosis.
Or anisocytosis, okay? And why is this important? Because sometimes, for example, you'd have an anemia that presented as microcytic, which means they had low MCV, but one of them has normal RDW and one has increased RDW. You're able to differentiate the cause of the anemia. So for example, normal would most likely be due to thalassemia, which is a hemoglobinopathy, and increased most likely due to iron deficiency anemia. So looking at these parameters, you're able to tell between different types of anemias. And how do you remember this? Maybe because, for example, in iron deficiency anemia, some cells get to have more iron than others, so some of them get to grow bigger than others. But in thalassemia, since it's a genetic mutations and all the blood cells have the same, all the hemoglobin has the same mutation, then they're all the same size, maybe like that. So next thing is mean corpuscular hemoglobin. Mean corpuscular hemoglobin or mean cell hemoglobin is the average concentration of hemoglobin in a red blood cell. I'm sorry, wait, how do they have thalassemia if it's not a normal red blood cell. It's not a normal red blood cell, it's normal or low distribution width, which means that all of the cells are the same size. Doesn't mean that they could be all smaller than normal, but they're all the same size. But this one, they're all different sizes. Does that answer your question? Yeah. Okay. So like we said, MCH is the average amount of hemoglobin in a red blood cell, okay? And what gives red blood cells their color? Hemoglobin, right? So hemoglobin will give the red blood cells its color. So if it's normal, if there's a normal amount of hemoglobin in the red blood cells, then that would be normochromic, chromic meaning color. So they would look like normal color. But if it's below normal, then it would be hypochromic, okay? And it would appear as a central pallor. So here, if I give you, for example, this would be normal or hypo.
Normal.
This is normal. This is the normal RBC. It's normochromic. But this one would be
Hypo.
hypo, right?
Hypo.
And this is even more severe hypo. Do you see the central pallor, right? So this is how you know that this is hypochromic. That means it has low amounts of hemoglobin inside, okay? And you might ask, why is there no hyperchromic? But from what I've seen in the slides, it's that you can't, like the maximum amount of hemoglobin that you stuff inside, that's the normal. If you stuff in more, then yes, someone said it. Yeah, Bilal is right. The cell might just burst, okay? So mean corpuscular hemoglobin concentration, or MCHC. The difference is that this is the concentration of hemoglobin in the cell, not the amount, but the concentration, okay? The average amount of hemoglobin concentration in RBCs, okay? If it's above normal, it usually signals something that might be like spherocytosis, which you guys don't really have to know. Like, we don't really use MCHC a lot in first year, but this is a type of disorder where their cells are a bit dehydrated. And because they're dehydrated, the same amount of hemoglobin, it kind of is just more concentrated, okay? So this is MCHC, okay? The last thing, which is reticulocyte count, this is not part of CBC. All of these were CBC, this is not CBC. And reticulocyte count, it looks at the number of reticulocytes and they're expressed as a percentage. So for example, 2% reticulocyte, 1% reticulocyte, okay? But what is a reticulocyte? Question. It is kind of an erythroblast. Yes, it's the immediate precursor of the red blood cells, right? And since they are the immediate precursor, they still have some remnants of RNA, okay? And why is this important? You'll see now, but basically they're kind of bluish. So as you can see here, they're kind of bluish. Honestly, I don't see the difference. If you'd ask me, I'd say they look more purple than bluish, but they're bluish to a normal RBC. And polychromasia. So they kind of have like different colorings inside. This would be an example of polychromasia. They're kind of larger than an RBC, which makes sense. But the important thing is that you're going to see remnants of RNA. So you put a special stain and you're going to see these blue dots. These are remnants of RNA. So that means that these cells are reticulocytes. If you don't really see a lot of remnants, this is an RBC, okay? A mature RBC. So if it's above normal, if reticulocyte is above normal, then that means that the bone marrow is producing a lot of RBC. There's increased production of RBCs, hyperproliferation. And if it's below normal, then there's decreased production of RBCs or hypoproliferation. Proliferation means division, so hyper means extra proliferation, and hypo means less proliferation, okay? So now I want you guys, either you unmute yourselves or you can write in the chat, but you have to answer these. So if MCV is above normal. Yes, the recording I think will be uploaded on YouTube. So if MCV above normal, what do you call it? Macrocytic. Does everyone agree? Okay, you're correct. Yes, it's macrocytic. What does low RDW mean? Does everyone agree? What does low or normal RDW mean? Yes, anisocytosis is high RDW. Yes, the cell sizes there's little variation in the cell size. Okay. Increased MCHC. Example. What is MCHC? Yes, spherocytosis. You're correct. Okay, so spherocytosis. MCHC is, we said, the concentration of hemoglobin in the cell. And in spherocytosis, it increases because the cell is slightly dehydrated. So it's like kind of has less volume, and therefore the amount of hemoglobin is just more concentrated. Okay. If MCH is normal, what do we call this? Does everyone agree? Yes or no? Okay. Yes, correct. Okay. Higher reticulocyte count. What does that mean? Yes, hyperproliferation. The difference between MCH and MCHC, MCH is the amount of hemoglobin, the average amount of hemoglobin in the red blood cell. And if it's below normal, you would call it hypochromic. If it's normal, you would call it normochromic. MCHC is the concentration of hemoglobin in the cell. So it's not the amount, it's the concentration. For example, the cell can be smaller in size and have low amount of hemoglobin, but the concentration will still be normal. No problem. Okay, if MCV is normal, what does that mean? Normocytic. An example of high RDW. Example. It is anisocytosis. Iron deficiency anemia. Yes. If MCV is below normal, what do we call this? Microcytic. Okay. High RDW, you already mentioned anisocytosis multiple times. So yes, anisocytosis, increased variation in size. Low reticulocyte count. Low reticulocyte count. Yeah, hypo. If MCH is below normal, yes, it's microcytic. And an example of low RDW, when all the cells are the same size. Thalassemia. Yes, perfect. Okay. So checkpoint. Do you guys have any questions about everything I mentioned previously, or do you have it in your mind now? Anything? No? To move on? Okay. So now we're going to move on to the classifications of anemia. So anemia can be classified two ways. First way is through morphology. So by its shape, and morphology is divided into microcytic hypochromic, or normocytic normochromic, or macrocytic. There's no hyperchromic, okay? Microcytic hypochromic, normochromic, normocytic normochromic, and macrocytic. And by underlying mechanisms, it can be either due to blood loss, or hypoproliferation, or hyperproliferation, okay? And we're going to go over each one of them. So first thing, by morphology. Starting with microcytic hypochromic anemia. So this means that the MCV and MCH are high or low? Low. Yes, okay? So there's low MCV and MCH. And if we know the red blood cells, they don't have a nucleus, they don't have mitochondria, they lack most of the organelles, and they're mainly filled up with hemoglobin, right? So if there's a problem with the hemoglobin, then that's most likely what's causing a microcytic hypochromic anemia, okay? And the problem with the hemoglobin, it can be either from the heme, which is the iron-containing component of hemoglobin, or from the globin chain, okay? And an example of defect in heme synthesis is iron deficiency anemia, because heme needs iron. If you have iron deficiency, then you're not going to be able to produce heme, okay? Another example is anemia of chronic disease, and I think you took it in your iron metabolism lecture, but in chronic diseases or chronic inflammation, the body does not allow the blood cells to use the iron to make heme. So you have iron, but it's not being able to be used to make heme, okay? And for globin, an example is thalassemia, which we're not going to go into today. So we're not going to hemoglobinopathies, okay? So which one is this normal, or the second one is, or which one is abnormal, the first or second? The second one. Can you see the like hypochromia? I think it's very clear here. The cells are very pale compared to these normal ones, right? And some of them are kind of smaller, some of them are kind of bigger. What is this called? When some cells are bigger, some cells are smaller. Anisocytosis. Yes, okay, perfect. Now to normocytic normochromic anemia. So from the name, the MCV and MCH are high, low, normal. Yes, okay. So there's normal MCV and normal MCH. So what might cause this? Number one is acute blood loss. So in acute blood loss, basically you lost blood, but whatever blood you have remaining is normal, right? Nothing happened to it. You just lost blood, right? The other thing is anemia of renal failure. Can anyone guess why anemia of renal failure? You guys can type or unmute yourself, Adi. Why would renal failure cause anemia?
Failure to produce erythropoietin.
Yes, exactly. Perfect. So in renal failure, what happens sometimes is the kidney is not able to produce enough erythropoietin anymore. And as we know, erythropoietin is the thing that stimulates the process of erythropoiesis, or the formation of red blood cells. So if you have less erythropoietin, then we form less red blood cells. But the blood cells that are formed, they're normal, right? Okay. So that's why it's normocytic, normochromic. I couldn't find an image, so I just got a normal thing, but they probably have less red blood cells. Now macrocytic anemia. Macrocytic anemia means that the MCV is high, low, or normal? High, okay? So there is high MCV. And macrocytic anemia can be divided into two things, which is megaloblastic macrocytic anemia or non-megaloblastic. We're not going to get into the non-megaloblastic, but megaloblastic example is B12, vitamin B12, or folate deficiency. And what makes an anemia megaloblastic? It's basically, megaloblastic is when you see hypersegmented neutrophils in the peripheral smear. What are hypersegmented neutrophils? They're neutrophils. How many lobes should a neutrophil usually have? From morphology, 3 to 5. So if it has more than 5, if you see a neutrophil that has more than 5 lobes, then that's a hyper-segmented neutrophil. So it has more segments, more lobes, okay? So then you know that it's a megaloblastic anemia, but it's not a megaloblast per se, but yeah. So as you can see here, this is a hyper-segmented neutrophil, okay? And if you see these cells, they're so large in comparison to the other normal red blood cells, right? So yeah, so this is a normal peripheral smear, and this is a megaloblastic anemia kind of image, okay? So now, in microcytic hypochromic, what's the MCV and MCH? We're going to repeat everything we just said. What's the MCV and MCH? MCV low, MCH is low. Okay. Examples of microcytic hypochromic. Yes, iron deficiency, because it's a problem with the heme. We said usually it's a problem with hemoglobin, right? So if it's a problem with hemoglobin, it could be a problem with heme or globin. So heme iron deficiency, another example. Problem with the globin chain, for example, thalassemia, okay, anemia of chronic disease and thalassemia. Now, normocytic, normochromic, the MCV and MCH are normal, okay. Examples of normocytic, normochromic, someone mentioned it. Someone mentioned it above, thalassemia. Yes, so renal failure, anemia of renal failure is not microcytic hypochromic. It's normocytic normochromic because the red blood cells, they're normal. It's just that they have less stimulus to produce the red blood cells. They have less erythropoietin. And yes, acute bleeding hemorrhage, the same thing. The blood is normal, you just have less of it because you lost it, okay? Macrocytic, what's the MCV? High. Okay, examples of macrocytic. It's two deficiencies. Vitamin B12 or folate deficiency. Yes. Okay. Checkpoint. Do you guys have any questions about dividing by morphology? Classifying anemia by morphology? Okay. If there's no questions, I'm going to move on. So now we're going to classify anemia based on the underlying mechanisms, starting with blood loss. And blood loss itself can be divided into acute blood loss and chronic blood loss. So in acute blood loss, what happens? It's usually due to trauma. So like trauma that caused the hemorrhage, they were in an accident, surgery, something that caused an acute blood loss, okay? And in the beginning, the hemoglobin will actually be normal. So if you take a sample, the hemoglobin will be normal. Why? Anyone guess? You can unmute yourself. You can say anything.
Hemoglobin structure is unaffected.
Yeah, no, but the concentration of hemoglobin will be normal. Like if you take a sample of the blood, the CBC will not show anemia per se, even though they lost a lot of blood.
So same concentration?
Right, exactly. So basically, say for example, you have a cup of water and you added 1 tablespoon of salt and you mixed it in. So now there's like 1 grain of salt per liter, not liter, whatever, 1 grain of salt per drop of water, for example. And you spilled half of the cup. And now you have half of it left. And if you take it and measure it, there'll still be 1 grain per drop, right? The concentration doesn't matter. So it's not going to show anemia. When is it going to show anemia? When the body starts compensating for the lost fluid and it adds more fluid and the blood becomes more diluted. Or when the people at the hospital themselves, they're going to give them fluids. So it's going to show them as anemic. But they do truly have less blood cells. But they just lost the red blood cells and the fluid all together at the same time. So the concentration is the same. And then after 2 to 3 days, you're going to see reticulocytes. Now the body is kicking in and it's trying to make it more and more red blood cells. So you're going to see reticulocytes, okay? In chronic blood loss, it's usually due to GI bleeding from colorectal cancer, for example, or ulcers, and or menorrhagia. And menorrhagia is basically when there is heavy bleeding in the female's menstrual cycle, okay? So these can cause chronic blood loss. And this chronic blood loss is going to cause iron deficiency anemia. So chronic blood loss causes iron deficiency anemia, okay? And it's very important that if a man presents with iron deficiency anemia, you will suspect that there's some sort of bleeding. So they will usually go do a colonoscopy or something, check if there's any GI bleeding. But for a female, having iron deficiency anemia is kind of normal, so they will not suspect something serious. But for men, if they present with iron deficiency anemia, you always have to suspect that there might be bleeding somewhere, okay? Now, the second mechanism, which is hypoproliferative. So from the name, we have less proliferation or less divisions of production of red blood cells. So it's basically the inability to produce adequate number of RBCs in response to appropriate stimulus. Yes, you're correct. Low reticulocyte count. So that was the next point. So low reticulocyte count. So what are some causes of hyperproliferation? So the first thing is that if you have nutritional deficiencies like iron, B12, folate, so you're deficient in something that is needed to produce the red blood cell, so obviously you're going to produce less red blood cells. There's going to be hyperproliferation, right? Another thing is aplastic anemias. Aplastic anemias, from the name, A means no, and plastic from plasia or division, so no division anemias. So these are the type where the bone marrow itself, for some reason, it's not dividing and it's not producing enough red blood cells, okay? Or anemia of chronic disease, which causes iron deficiency anemia. Or anemia of renal failure, again, because there's no erythropoietin, so you're producing less, okay? So all of these kind of make sense why they're hyperproliferative, right? Okay, moving on to hyperproliferative. So hyperproliferative anemias, the name is kind of confusing because if it's hyper, that means we're dividing more. So how can me producing more red blood cells cause anemia? But it's kind of a misname, I would say. So it usually happens in hemolytic anemias. And what is a hemolytic anemia? It's when the red blood cells are destructed prematurely. They're not supposed to burst now, but they're breaking or being destructed very fast. So this is hemolytic anemia. And because there is increased destruction of RBCs, the body will try to compensate by what? By increasing the production of RBCs. So there will be hyperproliferation in response to the increased destruction, okay? I hope that makes sense. So you'll find a high reticulocyte count because the body is hyperproliferating. The blood, there is a lot of blood being formed because of those hemolytic anemias, okay? So any cause of hemolytic anemia would be hyperproliferative. So for example, are the reticulocytes defective? It depends on what's the cause of the hemolytic anemia. So if it's genetic, then there's a problem in, for example, in hemoglobin, like here, thalassemia or sickle cell anemia, then yes, there's a problem. There are problems with the reticulocyte, probably with everything because it's genetic and they need the hemoglobin. But if it's acquired, so for example, here, immune hemolytic anemia, basically, for example, someone gets infected and for some reason, or autoimmune, for some reason, the body's own autoantibodies or antibodies attack the red blood cells and lyse them, and now you have hemolytic anemia. So here the reticulocytes are normal, okay? But in the end, what happens is that you have hemolytic anemia and it causes increased productions of RBCs. Does that answer your question? Yes. Okay, yeah. So this is hyperproliferative, okay? So now we're going to match those with their things that they should be matched to. So inability to produce adequate RBCs, what is that? You can just write like, for example, acute, chronic, hypo instead of the full thing. Inability to produce, hypo. Does everyone agree? Okay. Hemolytic anemias. Where do they fall into? Hyper. Does everyone agree? Okay. Yes. So hemolytic anemias, we said, because there's increased destruction of the RBCs, then we will try to compensate and have hyperproliferation. Okay. Trauma. Acute blood loss. GI bleeding or menorrhagia. Chronic blood loss. Thalassemia. Thalassemia chronic. Oh, no, sorry. Wait, yeah, thalassemia. What does thalassemia belong to? Hypo or hyper? Hypo? Everyone agrees on hypo? Actually, it's hyper. If I go back, thalassemia is a sort, it causes hemolytic anemia. Sickle cell anemia also causes hemolytic anemia, basically because they have a problem with the hemoglobin. So it would be hyper, okay? So thalassemia is hyper and not hypo. Hypo is usually deficiency or you're not able to produce the red blood cells, okay? So hyper. Nutritional deficiencies. Hypo this time, yes, it is hypo. You see reticulocytes after 2 to 3 days after this. Hemoglobin is normal at first, then you see reticulocytes. Yes, acute blood loss. One of them causes iron deficiency anemia. Yes, so chronic blood loss causes iron deficiency anemia. Aplastic anemias, where do they belong? Where do aplastic anemias belong? So A means no, plasia means division. There's no division. Hypo, does everyone agree? Yes? Okay, yes. Aplastic anemia is hypoproliferative, okay? And we're going to look at aplastic anemia right now, okay? So this is classifying by underlying mechanism. Does anyone have any questions from the previous parts or this part? All good to go? Do you know everything? Clear? Okay, perfect. So now we're going to move on to the last part of our lecture. What is chronic blood loss? So it's when you're slowly losing blood for a very long time. So for example, you have an ulcer in your stomach, for example, and it's bleeding slowly, and no one notices it, and it continues on bleeding. It's chronic. But acute, you got a trauma and you lost all this blood right now. Does that answer your question? Yes. Okay. Yeah. So chronic means for a very long time. Acute means short and sudden. Chronic is usually like, it's not sudden, it's gradual and for a very long time. Okay. So iron deficiency anemia. The pathophysiology of iron deficiency anemia is usually there's chronic blood loss, but sometimes it could be for some reason you're not able to absorb the iron, maybe dietary, but for some reason you have less iron in your blood, okay? So in chronic blood loss, it's because you're losing more iron. Is there any symptoms of chronic blood loss? Well, it depends on where the blood is being lost. So for example, in GI, usually they will present with some, if it's an ulcer, usually they will present with pain. But if it's a cancer, colorectal cancer, they will usually not have symptoms until it's late. It depends. Okay? Clear? Does that answer your question? Okay, no problem. To be honest, I don't remember the iron metabolism lecture, but if there is deficiency in iron transport, then definitely there would be problems with the heme. I don't know if if it causes decreased like absorption and therefore you'll have less iron in your body, then yes. But if it's a problem that your body is not able to utilize the iron, then I don't know if they would call it iron deficiency. I'm not sure about that. Okay. I can search up that for you. Yeah, then if it's not able to enter the enterocytes and then it's a problem with the absorption of iron, then yes, you would get iron deficiency anemia, definitely. So if you have malabsorption or this is the most common cause, you're chronically losing the iron through chronic blood loss, then you will have decreased iron in your body for some reason, also the malabsorption, so you'll have decreased iron. And if you have less iron, then you will have less heme synthesis, right? Because it's needed for the heme. And if you have less heme synthesis, then you will have less hemoglobin. And if you have less hemoglobin, they will have less red blood cells, and therefore you have anemia, right? Does this pathophysiology make sense? All good? Okay. So, it gave an answer, no. Okay, so what's the morphology of iron deficiency anemia? Under what classification by morphology does it go? I mean, is it macrocytic or is it normocytic, normochromic, or is it hypochromic, microcytic? Microcytic, hypochromic. Does everyone agree? Yes, okay. So it's microcytic, hypochromic. By underlying mechanism, is it hyper or hypoproliferative? Does everyone agree with Bilal? Okay. Hypo. Perfect. Okay. So yes, hypo. Reticulocyte count, will it be low or high? Low. It's hypoproliferation, so it's going to be low. Okay. So how will they present? Just like any normal anemic patient, they would have fatigue and pallor. But there's something very specific for iron deficiency anemia. It's only iron deficiency anemia, which is called cholinekia. Which is called cholinekia. And it's basically like the spooning of the nail. As you can see here, there's spooning of the nail. So this is only for iron deficiency anemia. Another thing is pica, which is also again associated with iron deficiency anemia, which is basically they crave for non-food item like ice or soy. Pretty sure a lot of the people here eat ice, but yeah, okay. And then another thing is called angular stomatitis. So from the name angular, so it's at the angles, and stoma means opening. So at the opening, so it's like the angular inflammation at the corners of the mouth. And this is not specific for iron deficiency. It could be also in B12 and other some sorts, but it is in iron deficiency, angular stomatitis. Okay. So here we have a blood smear. So what can you see? This is the blood smear of iron deficiency anemia. What's different? How would you describe it for me? You can unmute yourself. Typing is difficult.
Teardrop cells.
Teardrop. Yeah. Pencil. Yeah. Like, how would you describe it? The size, the shapes, the color. Microcytic. Okay. More
Hypochromic.
areas. Yeah. Hypochromic. Do they all look like they're the same shape? Or are they different shapes?
Isocytosis.
It is anisocytosis, yes. Anisocytosis is different sizes. Shapes, are they all the same shape? Or are they the same, are they different or are they the same?
Leukocytosis, I think.
Sorry? Can you repeat it?
I think pulcocytosis, something like this.
Very,
with
very
a P.
close, yeah. It is with P. If you write that in the exam, they're gonna accept it, صراحة. I don't think many people do remember the name, but it's poikilocytosis. One of my friends was saying that kilo it means weight. So if you drop a weight on the red blood cell, it's going to change shapes. I don't know if that's gonna help, but it's poikilocytosis, okay? And anisocytosis, hyperchromic, microcytic, and yes, you can tell some specific types of shapes. So now this is from your iron metabolism lecture. But what would the serum iron be, high or low in iron deficiency anemia?
Serum iron low.
Serum iron will be low. Ferritin?
Low also.
Ferritin will also be low. Transferrin saturation will be high or low. High. Wait, so I saw it decreased. Maybe it is high. I'll have to check that. What about TIBC? The binding capacity? Yes, so the binding capacity will be high because there's a lot of capacity for the iron to bind. Okay. So yeah, okay. Moving on to megaloblastic anemia. So megaloblastic anemia, basically most of the time it's due to poor diet, or there's again malabsorption, or there's some drugs that do things, and you'll end up having vitamin B12 or folate deficiency. Okay. And if you have vitamin B12 or folate deficiency, both of them are needed for DNA synthesis. And DNA synthesis is needed for nucleus maturation, okay? So if you have normal DNA synthesis, you have normal nuclear maturation. But the RNA does not need vitamin B12, and so RNA will be normal. And therefore, the cytoplasm, which depends on the RNA, it will mature normally and will grow normally. So what will end up happening is that you're going to have that the cytoplasm continues on maturing and growing while the nucleus is still immature. So you'll end up having a large cell with nuclear cytoplasmic asynchrony, which means that the nucleus and the cytoplasm are not on the same page in maturation, okay? And this large cell that has nuclear cytoplasmic asynchrony, this is called a megaloblast, okay? So this megaloblastic anemia, by morphology, what is it under? Hypochromic microcytic, normal chromic normocytic, macrocytic. Macrocytic, does everyone agree? Yes, okay. Underlying mechanism? Hypo or hyperproliferative? Hypoproliferative, and reticulocyte count will be low. Perfect, okay. Again, they will present with fatigue and pallor in the same angular stomatitis that we saw before, okay? Might present with it. Okay, so this is a blood smear. What do you see? very specific feature of a megaloblastic anemia. Yes, this hypersegmented neutrophil. It definitely has more than 5 lobes. 1, 2, 3, 4, 5, 6, 7. So yeah, okay. Oh, why did all answers repeat together? Okay, so yeah, hypersegmented, and also you're going to see that the cells are larger in size. They're kind of oval, but there's a lot of large cells in here, okay? In the bone marrow, you're going to see the megaloblastic cells or the megaloblasts, which are giant red cells or neutrophil precursors with the nuclear cytoplasmic asynchrony, okay? So this is what megaloblastic anemia is. The last thing, which is aplastic anemia, okay? Aplastic anemia is basically when there's bone marrow insufficiency or that we have few hematopoietic precursors or stem cells in the blood, in the bone marrow, I mean. And therefore, since we have few of them and they're kind of barely dividing, we have decreased number of blood cells, all of them, white blood cells, red blood cells, platelets, okay? So in aplastic anemia, it's not just red blood cells, all of them will be deficient or low. So what would cause aplastic anemia? Usually it's idiopathic, like there's no actual reason, no one knows why this person just suddenly started having aplastic anemia. But sometimes some infections or some drugs, some hereditary conditions can cause aplastic anemia, okay? But most of the time it's idiopathic, okay? In the CBC, you would see pancytopenia. What does pan mean? Pan means all. Pan means everything, okay? So all cyto cells, penia deficient. So all of the cells are low. There is a lack of all the cells. Red blood cells, white blood cells, platelets, okay? So this is a very important finding of aplastic anemia, that you're going to find that all cells are low. And the classification of the anemia by underlying mechanism, what is it? Hyper or hypo? Hypo? Everyone agrees? Yes? Okay. So yes, it is hypoproliferative. Reticulocyte count, will it be low or high? Low. Okay. So, very important test. Since we said that the problem is in the bone marrow, in aplastic anemia, you will check the bone marrow, yes, biopsy, and you're going to see which one feels abnormal. Like, what are you going to see? What are you looking for? Hypocellular, yes. So this bone marrow is very empty compared to this. Look at how many cells this has and very few white spaces. This one is very empty, okay? So in aplastic anemia, you're going to see pancytopenia and you're going to see an empty bone marrow, okay? So it's very important. Tamam? So now, are these gaps adipose? Yes, I think they're fat that's being washed out because you don't actually see the fat. It gets washed out when you fix the tissue and you're just going to see white empty spaces. Okay. Yes, correct. During the processing. Okay. So now what kind of anemia is this? What's this anemia? The diagnosis from the peripheral smear. Megaloblastic. Does everyone agree? Yes? Okay, why did you say megaloblastic? What features did you see that made you think that it's megaloblastic? Hypersegmented, perfect. And another thing? Two things. Macrocytic, perfect. Okay, so you're going to see macrocytic cells and hypersegmented nucleus. What causes megaloblastic anemia? Two causes. B12 and folate deficiency, yes, okay. So vitamin B12 deficiency, folate deficiency. What's the underlying mechanism of megaloblastic anemia? Hyper or hypoproliferative, that's what I mean. Hypo or reticulocyte count. And guys, please, in the exam, focus if the doctor is asking about morphology or is he asking about underlying mechanisms. Because sometimes he'll be like, what's the underlying mechanism of megaloblastic anemia? And he will put both macrocytic and hyperproliferative, and you might choose macrocytic by mistake. So read carefully what the question is asking you for, okay? So yes, it's hyperproliferative. What is this? Aplastic? Does everyone agree? Okay, yes, it's aplastic anemia. Why is that? What did you see in this image that made you think it's aplastic? And what can you see in the CBC? Pan, okay, pancytopenia, and it's hypocellular. Yes, there's empty bone marrow. Okay. What causes aplastic anemia? What's the usual cause number one? Idiopathic. So that's the main cause. Yeah, it's not a cause. We don't know the cause. It's idiopathic. But sometimes it can be like drugs or infections. Okay, underlying mechanism. We only took hyperproliferative, so I'm going to do this for you. Hyperproliferative. This one. What is this? What anemia is this? From the image. Iron deficiency. Yes, iron deficiency anemia. What features did you see here? 4 features that made you think that it's iron deficiency anemia. You need to know the names of these 4. Sickle? Did you mean that this is a sickle cell? Yeah, microcytic hyperchromic, but for the sickle cell, they usually like it's fully colored from inside. The sickle cells, they're like fully colored. There's no pale center. And yeah, but this is not sickle cell anemia. Usually. So yeah, pencil cells, elliptocytes, hyperchromic, microcytic hyperchromic. Okay, two features important. You need to know the names, difficult names. Are the sizes different? Are the shapes different? Are they all the same shape or are they all the same size? And isocytosis, which means they have different sizes. Poikilocytosis. Yes, perfect. Okay. So these are the 4 features. You have to memorize them like your name, honestly. They come a lot. Causes. What causes iron deficiency anemia? What can cause iron deficiency anemia? There are many causes, but give me one of them. Thalassemia causes microcytic hypochromic anemia, but it doesn't cause iron deficiency anemia. Lack of B12 will cause megaloblastic macrocytic anemia. I'm asking what would cause iron deficiency anemia. So what would cause like deficiency of iron in the blood? Thalassemia is genetic. You're going to take a PAL, I think, on the hemoglobinopathies, where you're going to take thalassemias and you're going to take hemolytic anemias. We're not taking hemolytic anemias today. So it's all hyperproliferative. But hemolytics are hyper. Chronic, yes. Chronic blood loss will cause, can cause iron deficiency anemia and iron malabsorption. Like someone mentioned before, I think Bilal, he said like malabsorption, yes, can cause iron, okay? Underlying mechanism is hypoproliferative, okay? So now, this is a checkpoint. Did you guys understand or do you have any questions related to anything I mentioned before? Or is it all clear and we can move on? No questions? Okay. So that was the end of the explanations, but I have some questions for you. Okay, so let's see if you can answer them. So this is the first question. A 17-year-old complains of fatigue and has recently beginning to feel heart beating in exam. Oh my God. I'm sorry. Basically, the CBC shows MCV is 69. The normal is 80 to 100, so they will always give you the normal range. Which of the following is the most likely cause of her presentation? Sickle cell anemia. Okay. Anyone has another answer? Iron deficiency anemia. Anyone has any other answers? Or you can choose one of these two answers. Okay. B. Okay, so the majority is choosing B. So the answer is B. Why is it? So number one, or the main reason, is that this one, the MCV is low, which is below normal. The normal is 80 to 100. So always look at the exam, the normal. If it's below normal, then it's microcytic. B12 and folate are out of the questions. They're both macrocytic. Hereditary spherocytosis, not really not really what our topic was about today. Neither sickle cell anemia, but sickle cell anemia deficiency, or sickle cell anemia basically would not present like this. Sickle cell anemia, we do not say sickle cell has a specific shape. Like those cells, most of the time they're normal. But then when suddenly a crisis happens, someone has lower oxygen than normal, then they get a crisis and it changes into a sickle cell or a sickle shape. So yeah, it's not really macrocytic. Plus, they would not present like this. People with sickle cell anemia would have a more severe presentation if they were to undergo a crisis. They would have pain, swollen joints, and stuff like that. Okay, so here the answer is iron deficiency anemia, mainly because it's really the more common anemia in teenage people and adolescents and children. It's a very common anemia. Okay, here a 20-year-old male presents with pallor and episodes of fever and petechial hemorrhages on his lower limbs. Okay, his CBC shows hemoglobin is 8.5, MCV is 95. A bone marrow biopsy picture is attached. Which of the following is the correct classification for this anemia according to the underlying mechanism? C, hyperproliferative. Anyone has any other answer? C? Okay, yes. So the correct answer is C. And there are many clues. Even if you didn't see this picture, there are clues here, which is mainly the fever and petechial hemorrhages, which means that she has problems with her white blood cells. And petechial hemorrhages means that probably she has low platelets. So low platelets, low white blood cells, anemia, all of this, what is it called when all of the red blood cells, all of the blood cells are low? What is this called? Pancytopenia. Yes, pan means all. Okay. So there's the thing shows already that there's pancytopenia. So even if you didn't have this, you might be able to answer that. Oh, this is aplastic anemia, so this is hypoproliferative. Okay. Last question. A 20-year-old Black woman with a history of multiple small bowel resections for Crohn's disease presents complaining of fatigue and dyspnea. Physical examination is notable for pallor and a wide-based unsteady gait. Lab studies reveal a hemoglobin of 10 with an MCV of 120. Which of the following is the most likely cause of this patient's anemia? D, vitamin B12 deficiency. Okay, correct. So mainly here, she had the bowel resection, which probably means she has less absorption of vitamin B12. I know you guys might have not taken this yet, but the main thing here is, yes, it's macrocytic, right? So it's 120 macrocytic. So this is vitamin B12 deficiency. If there is folate, with a different scenario and you see macrocytic, then it's also folate. But here thalassemia is micro, anemia of chronic is micro, acute blood loss is normal, and iron deficiency is micro. Okay, so the only answer is D. Okay, so this brings me to the end of my session. Do you guys have any questions to anything that we did before? Any questions? It's fine. No? All clear? Okay, I hope it was a helpful session. Yes, the PPT inshallah will be shared with you guys. And I would really appreciate if you can fill this QR code. It's just one question. Oh, thank you. And I wish you good luck with your exam. Yeah, best of luck. If you can please fill the QR code. Thank you.